All right, good morning, everybody. First off, I want to thank you all for agreeing to be part of this recorded webinar and agreeing to allow me to use this to provide continuing education for folks ongoing. And so welcome to our engagement and retention webinar. This particular talk has resulted from some pretty extensive work that I've done with programs in trying to really engage their clients in a way that would lead to retention. I know people like Michael probably don't have that much of a retention issue because people aren't going anywhere in the prison system, but nonetheless, these engagement these engagement and retention tools are good for them as well, because it's really about trying to engage our clients. And if we can't engage them, they're not going to listen to us. They're not going to appreciate what we have to say. They're not going to trust us. They're not going to take on new ideas because we're just this blah, blah, blah. And so we really want to be able to connect with them. I had told you guys in a couple of weeks, we're doing this shame resilience webinar where we're really going to get into the empathy part of this. Which leads to Therapeutic Alliance. But we're going to get into some other stuff besides that empathy, and they're really specific, concrete tools that can be used. And really, what this resulted from was programs that I've worked with in regards to their retention and engagement. I set them up with a system that actually becomes part of their quality assurance program. So as far as the engagement is concerned, so what we do is have them track every single phone call. Every phone call, an inquiry form is filled out, and it's entered into the computer, and then we track whether or not they agreed to come in for an assessment. They track whether or not they showed up for their assessment. And then we also track, did they start the program? And so we actually have measurements in each of those areas. Looks like we have somebody else joining us. Welcome. Hopefully we can see your face. If you know how to do the video, it's lower left. And if you somehow don't have a video, just chat me and tell me that so I know you're there. Appreciate it. So we actually keep track of of people that called, what percentage of them agreed to come in for an assessment. So we call that inquiry to schedule. Okay. And then we track those who scheduled, how many actually showed up, and we track a percentage of that. And then of those that showed up, how many actually started. And then we have an overall number that goes from inquiry to conversion. And what that does is enables you to actually be able to see where the problem is. So is the problem that we just aren't doing a good job at getting them engaged even enough to schedule an assessment? Or is if they schedule, are they not showing up, and why? And actually in what I've seen is that is actually the biggest problem, because many times the assessment date is scheduled out for a week or two. Well, when they call, they're hot. They're ready to go. Well, what happens in a couple of weeks? They might get really cold to it, and then with people that are addicted, a lot of times they don't have very good record keeping systems. They might even just forget. And so being able to put in systems of reminder phone calls, and not only just one, but often, to where you're if there's just no way you can get them in sooner, you're calling them very often, keeping them engaged, keeping them interested, right? And then I strongly encourage programs to create an infrastructure that will allow for either same day or next day assessment. right? I mean, this is super important. When people call, that's an important phone call. We need to engage them as quickly as we can, get it while the fire's hot. That door slams very quickly, slams shut very quickly in this disease, and so we want to catch them right away. And so you know, as I said, measuring those different areas, you know, maybe our, you know, us, the people that are doing the assessments just aren't doing a very good job at engaging them and getting them to start the program. Maybe the people that are answering the call aren't doing a good enough job to actually get them, you know, get them interested enough to come in for the assessment. So so those are all areas that specific areas that can be measured. And by the way, you know, being part of the quality assurance program, what can end up happening is what you do is you measure the percentage in each one of those areas, and then you look for areas of that where there's problems, and then you create an action plan. You get together with your team, you create an action plan, you implement the action plan, and then you remeasure, like say the next quarter, and you see if your the what you implemented, you know, is actually working, and come up with what you call outcomes. And you do that monthly, and that's really good for, you know, your accreditation and for the state who wants to see you doing quality assurance as well. And then the other part of that is retention, is like, so of people that come into your program, do they stay? What percentage of the people complete the primary level of care, you know, in your program? I will say, and I think I said this in the kind of the advertisement for the for this talk, that um, uh, I've gotten programs to get so good at retention where there was one program that actually doubled the national average. I think the national average for completing the primary level of care in intensive outpatient, actually the national average was only about 38%. And we got that program hovering at 75 to 80% of the people that were coming into the program were actually finishing the IOP, the primary level of IOP, which is just astounding. I mean, I don't really like hearing about, you know, statistics and stuff, because I feel like people like it doesn't feel like sometimes people are really giving the facts straight, because that's not very often that kind of thing happens. And but anyway, I'm here to tell you that that did happen, and these tools that I'm going to give you today hopefully will allow you to improve your statistics as well. So what I'm going to do now is share screen to go to my slides. By the way, if you, I will be able to see all of you, even though I am doing the screen share. If you have any questions, you know, feel free to either just wait for me to take a breath, or you can raise your hand so I can see you. Or you can, I think there's a reactions function where you can raise your hand that way as well. And I'll check in with you guys every once in a while. So let's go ahead and okay, you guys see the screen, the slide?
Yes.
Okay, great. So let's go ahead and get right into it. So so the first thing that I want to share with you is some of the common pitfalls that I have seen at programs, you know, in the years that I've been doing consulting and the programs that I've ran, and it's very related to this talk that we're doing. So the first common pitfall is that programs appear to be more focused on increasing admissions than retaining their clients, right? So, you know, executive directors are, you know, they're responsible to keep the doors open, right? You know, and they boy, when they get a phone call, they want to get that person in, and there's a whole lot of focus placed on getting that person into treatment. And if they're you know, and some of the systems that I just told you was about, you know, getting people in, but they're not really focused on keeping them. Some programs that I've seen, I mean, literally people are flooding into treatment. They're getting so many people into treatment, But when you look at like how many people are completing the program, you get like maybe, let's say there's, 20 people or something like that in a month that are starting the program, but there's only like, 3 or 4 people finishing, every month. And people, so programs just are not paying enough attention to, once they get in the door, actually being able to keep them. And, when you're, I mean, this quality assurance program that I kind of spelled out for you guys, that um, it has fiscal implications on the program and their ability to be able to stay open, but it's only a byproduct of being able to help these people who have trusted you with their treatment, to get and stay sober, which is why they came in. I mean, it is very important for us to get them in. This is a very important phone call that happened. We got to grab onto that. It's what we're about. It's about, it's fulfilling our mission of helping these people. So when they call, boy, we want to get them in. But our mission should also be about not only just getting them in, but seeing that through and making sure that we're doing everything that we can from very early on in treatment, to keep them. The next common pitfall is that counselors are more focused on their goals for the client rather than on the client's goals. I first want to just say in regards to this, that our profession recently has been doing just a fantastic job on moving from what we call program-centered care to person-centered care. There's this old school, and I see this philosophy mostly in old residential programs, longstanding residential programs that have been around for 30, 40 years, where the attitude is kind of like, we've been doing this for 30, 40 years. We know what we're doing. If you do what we do, you too will get better. And so the program is as it is, and they expect the client to adjust themselves to this thing that works, right? And that will work for some clients, but there's a big percentage of clients that you're just going to miss that way, especially ones that maybe are not in the action stage of change. What about a person who has a nudge by the judge to get into treatment, or their employer's making them do this, or their spouse? If I have a program that is basically designed for people to get sober, and I'm not adjusting that to people who like don't yet want to be sober, then I'm going to miss those people. Why would they? I mean, they may stay because they want to keep their job or stay out of jail or whatever, but we're certainly not going to be able to move them toward wanting to get to stay sober and to really participate and pursue a recovery that has sustainability. I'm gonna so what has happened, especially with some of the public sector programs, with this ODS and Medicare Medi-Cal waiver, the state is actually requiring person-centered care, and so basically the program really has to be focused on the client's needs. Let me demonstrate what this kind of looks like. And this is, I'm going to begin to introduce again the Therapeutic Alliance, which is so important. So let's say a person calls, they said, they have to do treatment because the judge says that they're going to go to jail if they don't do it. So we get them in for the assessment, and then I do this assessment. And then, and it's a very, very thorough assessment. I'm using an ASAM and maybe other tools. And so at the end of the assessment, I say to them, boy, you know what? According to this, it looks like you got a pretty big problem with drugs and alcohol. So you probably ought to get sober, right? When I do that, especially when a person isn't ready to get sober, who am I aligning myself with there?
Yourself.
Anybody? This is a person that was sent to treatment by the courts or the judge.
You're aligning with the judge.
Exactly. So I become one of them, don't I?
Every
Right?
other authority figure in their life that has told them the same thing.
Thank you. Yes, yes. So instead, I do this, assessment, and it's like, okay, so, thank you for, all of the information you gave me. So, how can I help you? What do you, if you start this program, what do you want to get out of this? Well, I just don't want to go to jail. Okay. So you don't really want to necessarily get sober for long term. You just want to do what you have to do to stay out of jail. Yes, that's exactly right. And then I say, well, you know what? We can help you with that. The judge or whoever, or DCFS or whoever sent you, they trust this program to give you information that you need to be able to make a decision whether or not you want to be sober or not. And we're going to give you that information. So here's what it looks like. You enter this program. We're going to design a program specific to your needs. You do this program and you stay sober, and we're going to be able to write you this really kick butt letter to the judge or to DCFS saying that you completed the program, so that you can stay out of jail or so that you can get your child back. How's that sound? Sign me up, right? So what have I done there now? So in that scenario, who've I aligned myself with?
Them.
The client.
The client.
Exactly. And so that is what would lead to like a therapeutic alliance, you guys. I am not like trying to push my agenda off on this client. I'm not telling them what they should or shouldn't do. I'm specifically asking them what their needs are. And then, and once I establish that, I'm letting them know that I can meet them. And so I'm coming alongside them to help them meet their goals. And then, and then when we get them in, obviously, if this is a person that's in pre-contemplation or contemplation, then we can use, some motivational interviewing especially in our individual sessions that will allow us to move them along, those stages of change. Any questions about that? Does anybody feel like they're good at doing
I wanted
that?
to make a comment. Definitely in where I work, we work on meeting the client where they're at. I mean, so often we'll come in and it's, I have an issue with heroin, but marijuana is not so bad, and so okay, well that's great. Let's deal with this heroin addiction, and then later on we can revisit the, we don't say that, but at another point we can revisit the marijuana issue, or the alcohol issue, or the criminal behavior issue.
Yeah. You're talking about me, man. I don't got to quit alcohol and marijuana. I just got a little cocaine problem.
Right.
Yeah.
Yeah, I came here to get sober, not stop using marijuana and committing crime.
Yeah. So I want to just real quickly check in with, we have somebody that's in that doesn't have a camera, and I'm just wondering, do you have a camera? If you do, it'd be great to have you join us in that way. We are recording, so if you have a problem with that, with me using that for future continuing education recorded webinar stuff, it's fine to not have your camera on, but I do need to know that you're there. So if you could use the chat function.
Can you hear me, Bob?
Oh, yes, I can. Hi.
Okay. Sorry, I don't know why. I just dialed in on my phone and the camera wasn't an option, but this is Melanie Bucher with Alaska Airlines.
Oh, okay. Oh, perfect. Hi.
Hi, how are you?
You know what? I thought I recognized your name. I'm glad you joined us. Yes.
Yeah, I've been to some of your seminars. Thank you.
Yes, I remember you. Thank you for being here.
Yeah.
Okay, so so that's another of the common pitfalls, that counselors are more focused on their goals rather than the client's goals. And then inconsistency of the group facilitator. Now, I haven't seen this so much in the private sector, but for some reason in the public sector, when you look at the program schedule, there's like all these different types of groups, and they're really all really educational in nature. There's very little what we would call a group process. And it's mostly education. Last week in our group facilitation webinar, we talked about you know, the different types of groups, and encouraging people to figure out how to get, you know, to do you know, group process within their educational groups. But this inconsistency of the group facilitator. So what happens is there's tons of people in the program. I mean, some of these private sector, public sector programs have, you know, they might have, you know, 80 to 100 patients, you know, at one time, and they have, you know, a lot of different counselors. And so, so rather than like what I typically see in the private sector is that it's a 3-hour intensive outpatient group, and an hour and a half is education, and an hour and a half is group process, which I think is a great design. And typically what happens is it is the person's primary counselor that is doing those groups. So it's the person's primary counselor who's doing the education, and the primary counselor who's doing the group process. And so there's a very strong connection made, and it's really a design that facilitates the therapeutic alliance. On the other hand, in many of the public sector programs, there's tons of different clients. You assign them to maybe different tracks or different types of groups that maybe are individualized to them, but they could go through a week of groups and never see the same counselor. In fact, maybe not even see their primary counselor, the one who they're actually assigned to, and maybe the only time they get to see them is, you know, during individual sessions. I don't like this model at all. You know, they could do some really good really good, you know, processing, a really good job in one of their groups, and then like not see that group, not see the same people in the group, and not see the same counselor maybe for the rest of the week until they get back into that same group next week. And so any work that was done in there, they may be doing that same work in this group over here, and the same in group. There's no continuity, there's no connection with the group, and there's no connection with the counselor. And really, you guys, it's the connection that engages people, that leads to retention. If I feel like I'm connected to this group, I build a trust, I talk more, I participate more, and that participation leads to directly to retention, as we're going to see in a little bit. So I really, I've recommended to many of these programs to try to create a system by which the primary counselor has a certain amount of patients, and then they are participating in the groups. They're facilitating the groups that their clients are in. And if they're not able to do that personnel wise, well, I want them to design the program to where they're going to the same groups with the same people all week. Okay. So if they're in an outpatient program and maybe they're just attending an hour and a half group, you know, 3 or 4 times a week, well, they're on a track where those 3 or 4 groups, they're attending with all the same people. Okay, that connection gets built. Again, I think it would be great if they could have the same counselor all week, but at least if you could have the same counselor, you know, at least a couple of times, you know, out of those groups, that would be great. And then, you know, in the IOP program, they should be coming to a couple of hour and a half groups a week. Again, I like the design of doing an hour and a half education, an hour and a half a group process. And they would, again, be going to the same groups every week and with the same counselor. This is really an important issue. And so, you know, if you're running a program, you're going to want to try to figure this out. The 2 goals. One is, how can I get the person's primary counselor into as many groups with the client as possible? And how can I set it up? How can I organize my program in a way that this client is going to groups with the same people every group as much as possible? I've done this before. If you're interested in that, you know, I do have consulting services. There's a shameless advertisement. I can help you do that. And then another common pitfall is the lack of attention from the primary counselor. So part of that is just, you know, because of what I just said, if they're not doing any groups with them, they're not really getting a lot of attention from the primary counselor. And it may be that the only time they're seeing them is in their individual sessions. So if the primary counselor is not getting into multiple groups with the client each week, and it's just in the primary sessions, well, then I say that you need to increase your individual sessions, if at all possible. You get in there with them a couple of times a week. It would also be very, very important for the primary counselor to get their nose in the charts and see what's happening in their clients in the groups, so that they can truly coordinate this care and make sure that there's some continuity, and be following up with some of the some of the work that they're doing, and to be communicating with the group counselors that they are going to be in, when you want them to be focusing on certain things in their group. I'm also a very big proponent, as we'll see. I think I mentioned this later, but I'll mention it now in case I forget. I think it's really important that at assessment, if at all possible, that when the assessment is completed and they've agreed to start, that person is walked over to the primary counselor and introduced, so that they, like, before they walk out, that they've already met the people that they're working with. And if, again, if possible, hopefully they can actually have a short individual session with them. All right, and then minimal focus on therapeutic alliance. Those who know my work, those who have been to my webinars or trainings, how big I am on this therapeutic alliance. There's really nothing more important for treatment success than the connection that I have with the individual client. We're going to talk a little bit about that today, and a lot of this stuff that we're learning can help to build the therapeutic alliance, and I will help you. I'll point that out as we go. And so what I want to do is I'm going to stop share here and just check in with you guys. Any thoughts or comments about the stuff that we've talked about so far? Have you seen any of that?
One of the things that I enjoy about working where I'm working is we're small enough still that when I have a client come in, I'm able to do the assessment. So we can do the assessment straight away with the primary counselor, which for me is invaluable information. When I originally come in, instead of, I've worked at other places where they just hand you a file after the ASI, all the assessments are done, and you get this kind of brief history. But for me, I really enjoy the fact that I can sit down with my client and dig in a little deeper, ask a little more information, at the very beginning.
Not surprisingly, Michael, you're a step ahead of me again. I actually, this is one of the tools as we go on, as I'm in future slides. I actually point that out. One of the things, like, there's this one ILP program that I was working with where they had day and evening programs. And so as part of the inquiry process, when they make the initial phone call, we would ask them if they were going to be, if they, anticipated being in our day program or our evening program. And these, in this private sector program, they really had, there was one day counselor and there was one evening counselor. And so based on their response in that inquiry, we were able to know whether or not we should have the day counselor do the assessment or the evening counselor. And that you're absolutely right. Boy, don't you get a head start on your therapeutic alliance when you're the first one that sits down with them in that assessment, and that you've been able to make that connection. In fact, that's just so hard for the client. It's like they make this connection with like one individual and they're like, oh yeah, I can start this program. And then they get wished off to this other person that they haven't met. They show up and they go and sit in the group, and they might not even have met their primary counselor yet, and they go right into their group, and then they might not even meet their primary counselor before they leave. Nobody has even like really engaged them. They just have sat in this group, and then they go home, and then at some point, you know, along this first week of treatment, they're introduced finally to their, you know, to their primary counselor. So you know, if it's possible to have the primary counselor do the assessment, that is just totally ideal. And if not, boy, that handoff right after the assessment to the primary counselor is really important and would help. Thanks, Michael, for that. Anybody else have any comments or thoughts on this?
Like what Michael said, where I currently work, it's a residential treatment center. And if someone will come in, they'll go through the orientation with them, but then they'll hold off on doing the rest of their assessment and whatnot until the person that they're going to assign the counselor to comes in for their shift. And then they'll hand it over to them and let them carry on with the rest of it.
Nice.
So I think it's just great. From beginning all the way to the graduation of their treatment, it's with the same counselor who knows from the very beginning. They can build up a relationship. And you know, when a client first comes in, they don't want to divulge too much information. You know, they're just like kind of stand back, and they give you just enough information to kind of work with. But when you start out with them from the beginning, you build a relationship with them to where they start expressing more and letting more out, and you can get a lot further in their treatment that way.
You're absolutely right, Timothy. In fact, as we're going to see later in the talk, I actually make that connection. It's therapeutic alliance. Okay, so participation is like hugely important in retention. Therapeutic alliance is the biggest factor that will get people participating. If I built a relationship with them, right, a therapeutic relationship with them, they trust me, they're more apt to participate. And when they participate, that leads directly to retention. So you guys are right on the right track. That's awesome.
Yeah, I also never lead into an ASI or an ASIM when somebody first walks in. We always hit the smoking table first. We'll have a cup of coffee, chat it up a little bit, you know, just kind of get familiar, get them settled so that, you know, they get rid of that ease, and then go into doing the paperwork side of, you know, of going into doing their assessments. I found that works really well for me.
Yeah, we got a thumbs up from Timothy on that. And you get one from me as well. You know, I was actually just recently consulting for a program, and I was kind of looking at their whole program and you know, giving my evaluation of what they were doing. And one of the things that was really lacking is when they went in for the individual sessions, they were rightly using the treatment plan as a focus of those individual sessions, but they were just going right into it. It was like they would go in there and just open up the treatment plan and just starting reviewing it, like without even asking them how it's going so far or how's your day going. There was like no small, not even any small talk at all. It was just right into business. And so what you're saying is to actually sit there and engage them and just, you know, one human being talking to another and seeing how they're doing and expressing your interest in, you know, in them. Boy, that goes a long way, rather than, you know, toward opening them up, rather than going straight to business where, you know, they might not even really ever open up if you haven't like come to them as a human being toward them, rather than this counselor who has an agenda, obviously, to get through. Yeah, good stuff.
Well, Bob, one of the things that I've always, after all the years I've worked in treatment, whether clients make it or not, the one thing that I've found is that if they truly know you care about them, that's it. You know, the one thing, if I was to strip down 25 years of working in treatment, if they know I care about them, you know, one person to another, that's what really matters, whether they make it or not. Because I've had clients literally track me down through counties and find me and call me and say, I'm in trouble. Can you help? And that's the one thing, it's like they knew, you know, that if they got in trouble, they can always find me somewhere, and I'd be able to redirect them.
Yeah.
I think, you know, it's so key that human contact, one person caring for another is there.
Yeah, you're absolutely right. And like we talked about, in the group facilitation webinar, and what we're going to be talking about in 2 weeks in the Shame Resilience is, I'll bet you what that's about is that they trust that you get them. That when they're talking, that you are very interested in what their experience is, and you're willing to go over and sit in that stuff with them and go through it with them. So both being able to understand how they might be feeling, what they're feeling, what's behind that, putting yourself in their shoes, and then truly having that empathy, that, and that look on your face, and that approach that says, I really am interested in you and what your issues are. And, and I'm so sorry you're feeling that, that way. And let's get through this. And man, that is invaluable. And that's why they're tracking you down, because
Right.
I tell you, I wish there was more of it in our profession, but man, I've just been in too many group situations where I've seen the counselor just like kind of be in this intellectual, psychotherapeutic kind of modality where they just come from their head in dealing with the clients rather than, meeting them on an emotional level. And so great job. That sounds really good, Natasha. I want to go down that road. I'm all about that stuff.
Yeah.
we have a slightly different agenda, but it's definitely connected. I mean, if we're talking about engagement and retention, there's just really not more important than being able to
At
make
least the
that
engagement
connection.
piece, and the engagement piece, I mean, I know we can go down the road, that isn't on this agenda, but part of that engagement piece, I truly believe too, is doing your own personal work so you can genuinely engage with someone else. And I think that's where a lot of people get stuck in their head or things like that, and that's one of the things I've always tried to, really model for my staff and encourage them, is to do their own personal work so that they can, the genuineness, it's who you are.
Hmm. Were you sitting in my ethics class last Monday night?
No, but I sat in the one that we did on a Saturday.
Yeah. No, I teach an ethics class over at LMU, and we were just talking about personal and professional strengths and weaknesses, and it is so important for us to be able to do that work, because if I've got stuff, if I got my own stuff that's being activated all the time, and I'm not emotionally very stable, I can get like totally sucked in and kind of lose my emotional center in the middle of working with a client, because I have all this unresolved stuff going on. And when I am emotionally stable, I have the ability to safely go over and sit in their pain with them and still be able to keep my therapeutic distance at the same time. So
Right.
yes, huge point, Natasha. Okay, great discussion, you guys. I appreciate you participating in this way. So let's go back to, let me pull the slides back up. And gonna actually talk, there's some statistics here that, that I want you to see. So basically, this Berglund, Thielander, and Johnson, they reviewed a bunch of evidence-based, published and randomized control trials and psychological treatments of substance use. And so in a summary of what they found is, they found this: treatment is more effective than no treatment or being placed on a waiting list. You want to say no, duh, but this is very, very important, right? We can actually say, and you've heard this, I mean, this has kind of been a slogan for our profession: treatment works. What we do works. And so, that's, it seems simple, but it's something that is very important. What they also came up with, that specific treatments, like, with trained staff, theoretical base, structure, are more effective than standard or non-specific treatments, like just a supportive, counseling or social work intervention. But what they found is that no specific, of those approaches was superior. Isn't that interesting? So no matter what you like, your kind of your theoretical approach, and how you're approaching, as long as it's a specific treatment, no specific approach was superior. And then there's also little supporting evidence that exists for matching the type or level of intensity of treatment to the individual treatment. So not even like necessarily the level of care. There's just really little evidence that that matching clients up actually makes a huge difference. I mean, for the safety of the client, and I think maybe anecdotally we can see that some people are going to be doing better in residential than in outpatient treatment, but there really, at least at that time, was very little evidence. I actually want to spend some more time doing some more research. I really want to get into a master's program and actually start doing some research myself. But I wanted to show you this, and I'm kind of getting to a point, and you're going to laugh when I've gone way around the block to get here to where. So the contribution toward the outcome / success of treatment from the treatment model or evidence-based technique is small to negligible, right? Less than 1% of the variance. This is according to David Me Lee. You may have heard of him. So regardless of what technique, what evidence-based technique, which is surprising because there's like so much focus on evidence-based, techniques, it's small to negligible in regards to the variance of success in treatment. There's this Project Match actually found that all treatments work better than no treatment. Okay. And that no one treatment is better than the others, which is on the previous slide, which is what we found. So given that like all treatments work better than no treatment, and no one specific treatment is better than others, our therapeutic model, seems to have less than 1% of the variance. Well, what is it do you think that makes a difference? What do you think makes the difference, the biggest difference in success in treatment?
I would say attachment, like meeting the clients where they're at, how you're engaging.
Yes. And what does Bob Tyler call that? We talked about it earlier. Therapeutic alliance.
There we go. All right.
Right. Like how I went around the block for that one. So yes, therapeutic alliance between the client and counselor in a planned and structured treatment plan is what creates positive outcomes. So it's really the relationship that the counselor has with the client that makes the biggest difference. So I like this slide because it's like, I can't see the counselor's face there, but I'm assuming there's some empathy going on there, and then this other photo down here, where you see the connection there between those two, that's therapeutic alliance. All right. And then, so some other research, DiClemente, the person who did the stages of change, he basically says that treatment and other interventions are an adjunct to self-change, not the other way around. So it's not that we have this treatment and that's what leads the charge and then the client comes along with it. No, we are teaching the client how to self-change. Right? Our interventions are about teaching a client to self-change, right? And that's important because it's really the change and the desire to change has to come from the self, right? That's what the stages of change is all about, right? They have to have bought into the idea of change in order for that to happen. So we need to lead with that. Where are they at and go there as in regards to what stage of change they're in, and then say, okay, so you want to get sober? All right, Now we're going to help you do that. Okay. And then client or extra therapeutic factors are the greatest. Move my slide here on the side. Client extra therapeutic factors bring the greatest influence on change and are independent of treatment. So extra therapeutic factors are the things that the client brings, right? Such as their readiness for change. What is their level of readiness for change? Their strengths, resources, level of functioning before treatment, what's called premorbid functioning, social support systems, socioeconomic status, personal motivations, and life events. Those things actually bring the greatest effect. And now I push back on this a little bit because they say that it says that these are independent of treatment and therefore maybe we don't have an effect on that. Well, I think we do have an effect on that. We have an effect on readiness to change, don't we? If we're a client-centered program and not program-centered, we're going to meet them where they're at. And we're going to move them along those stages of change. We're also going to be helping them build support systems, and stuff. So I think we do have something to do there. But anyway, so it's estimated, according to WAMPOL, it's estimated that client extra therapeutic factors actually account for 80 to 87% of the variability in scores between treated and untreated clients. So basically what this says is that 80 to 87% of the success we actually don't have much to do with, which I hate this statistic because I would like to think that I'm having a greater influence than just 13 to 20% of the effect. But it's important because of this, that if you look at like this is the whole pie here. I don't know if can you guys see my arrow moving around there? Okay, so this is the whole pie, and then this in the center here is, so the green is the 80 to 87%, and what's left is that 13 to 20%. And if you blow that up, here's what you have. You have 5 to 8% of that is your alliance effects. 4 to 9% is the therapist effects, which combined, I think is this, combined is your therapeutic alliance. And then, 4% of that is like this expectancy or placebo effect. People, just because they're in treatment, will be, focused on staying sober, and maybe they're going to stay sober because that's what they're supposed to do in treatment, like this allegiance effect. And then there's the model technique effects, which is only 1%. So let's see. It seems like I had a question in the chat. Let me look at that real quick. Was wondering if you could email this material to print. Yes, I already did, Timothy. I actually sent the handout either last night or this morning. So you got that. If you didn't get it, go ahead and email me and I can send it again.
Thank you.
All right. So let's see. Where am I here? Okay. So Therapeutic Alliance starts with the first phone call. Okay, I got to stop share here because this is like really important, and I'm gonna demonstrate something for you. Okay, the first thing is when somebody calls our treatment center, and I don't get much pushback on this. This is perhaps the single most important phone call of this person's life. Right? I heard a statistic once, and I haven't been able to find it. I really want it so I can cite it for you. But the statistic basically showed that once a person realizes that they have a problem with drugs and alcohol, it takes them 2 to 5 years to do something about it. Okay? So most people, according to that statistic anyway, most people that realize that are calling your treatment center have known it for quite some time and are finally making that phone call. even if it's a nudge from the judge, even if it's a family member, even if it's a DCFS, even if it's the physician, they're finally making that call. Excuse me. So they get on the phone, they dial the number, phone rings the first time. Okay. First ring happens. They're nervous as heck. Their heart's probably pumping, right? You know, and so then the second ring happens. Now their heart's even pounding more. Now I'm going to have to be talking to a live person about this stuff. They're really super nervous, right? So then now let's transfer over to the treatment center, right? And many centers that I've worked at, they actually have counselors that are answering the phones, or whoever the personnel is answering the phones. They probably have other responsibilities as well. And so they're very busy. And so maybe there's multiple different people that could possibly be answering the phone. And so the first ring happens. And so if I'm really busy, I'm writing a treatment plan, or I've got insurance companies to call, or, you know, I have a group, you know, coming up, or I have an individual, you know, we're really busy in this profession. And that first ring happens. What may be the first thought that comes to my mind? I hope somebody else answers that phone, right? Now the second ring happens. Now my thought might be something, oh my gosh, are you kidding me? None of these other people are answering. Am I going to have to be the one that answers this phone again? Okay. So now go back to the person who's making perhaps the most important call of their life. Now the third ring happens. And by the way, I recommend at any treatment center, they should never go more than 3 rings. And knowing that, you know, so the counselor is, you know, the third ring's happening. Now they're probably hoping that nobody does answer, so they can just go ahead and, you know, leave a message regarding this, right? And now over the treatment center, the third ring happens. It's like, dang, I got to answer this thing again. Hello, treatment center. Really? For the most important call in this person's life, that's what they're met with? They're met with somebody on the other end of the line that in their voice, it says, you know, I'm really busy here. What do you need? What do you want? That's what the voice says. I don't really have time for you, but since you've called, I'm going to have to talk to you. So will you let me know what you want? That's what that voice says. And I'll tell you, I'm not going out on a limb here, because most of our people that are calling have low self-esteem. They maybe have abuse issues from the past, and that's exactly where they go with that phone call. Okay. We can't have people answering the phone like that. We have to be answering the phone and treating it as if it is the single most important call of their life. We want to sound, when we pick up that phone, like I have been sitting here waiting all day for your call, because it is the most important thing that is going to happen all day. Hello, this is Bob at such and such treatment center. How can I help you? Oh yeah, I'm calling because, you know, I have a problem with drugs and alcohol. Oh, great. I'm so glad you called. You know what, and you might, you know, ask them, you know, so what drug are you on, or what's caused you to make the call? And, you know, and they maybe get into it a little bit like that. And then it's like, you know what, that's like, I mean, you have totally done the right thing in making this call. We can totally help you with that. So here's what I want to do. I want to get some information from you so I can better, you know, so we can better move along and see what's the best path for you. And hopefully we can get you scheduled for an assessment so we can get you into treatment, you know, ASAP. How's that sound? And then you proceed with your inquiry call or whatever, right? So you have a lot of enthusiasm. You're instilling the idea that you're interested in what they want. You're instilling hope that what they want you can provide. Okay, hugely important. And it's from that first phone call that the therapeutic alliance is built. So my hope is that whoever is answering that call is building a connection in that first call, that by the end of the call, they're willing to come in and they're willing to schedule that assessment. And by the way, anybody that answers the phone, as long as you're able to meet those needs as evidenced by the information that you're getting in that inquiry, the goal of that call is to get them in for an assessment. I hate to use the analogy of a used car salesman, but you don't let them leave the lot without signing up, right? This is the most important call of their life, and you want to do everything you can to lead them into signing up, even if it's just, you know what, you're not going to be forced to do anything that you don't want to do. How about you just come in and talk to one of our counselors so we can like get the information, we'll do an assessment, we'll let you know what our recommendation is, and then you can let us know if you want to do it. Okay. The other thing that's really super important about this is I'm mentioning that what I just described is building therapeutic alliance from that first phone call. If a client gets something other than that, first off, they're going to get a bad first impression of the program because you're just going right to the inquiry form. And now they're just another call. They're just another number. They just want to get me in because they're trying to make money, and that's what they do. Now they've got a negative first impression. They may or may not agree to go ahead and come in for the assessment. And even if they do come in for the assessment, whoever is next in line to receive them, they have to overcome the damage in the therapeutic relationship that has been done by that first program, that first person, because the therapeutic alliance is not only built with that single person. I think on some level it's built with the program, right? So if that first phone call, if I get somebody that's just a machine, and is just filling out a form and just trying to get me, sign up, as regards to that program, I'm not feeling real connected. If I get that person that I just described on the phone first, I'm kind of expecting that next person that I'm going to be dealing with is probably going to be the same way. Same as if I've done a poor job on the therapeutic alliance on that first phone call, they're probably going to be expecting that. So the therapeutic alliance hopefully starts with that very first phone call and then is carried on throughout the treatment. All right, along those same lines, let me just check the chat real quick. Okay, Ava, I will send you the handout as well. So so the next piece of this is, while the first phone call is perhaps the most important event in this person's life, well, I think another hugely important event is when they show up for their assessment, isn't it? What do they get when they show up? When they walk into your center and walk up to the counter, what do they get? Do they have 3 people sitting in that nurse's station or in that workstation that are sitting there doing their work and are barely looking up when the person walks in the door? Are they like sitting there, writing a note or something and finishing up with, oh, just hang on just a second, they're having a conversation with staff, and it's like whenever they get around to finishing their conversation, they go and greet the person and say, oh, how can I help you? Right? No. What they should be met with is whoever is sitting in that reception area, they are getting out of their seat, walking up to the counter and saying, hi, and they should know, they should be knowing who's maybe expected. I mean, it may be that the program is only assessing one person at a time. You might know exactly who we're expecting to be walking in the door. You could even say, oh, hi, are you such and such? Or, oh, hi, how can I help you? Or, oh, hi, are you here for your assessment? Or welcome to the program. I'm so glad you came. This is such a big deal that you came, man. This is what an important first step. So are you here for your assessment? Yes. Okay, well, I'm Bob. So nice to meet you. Okay, so here's what I'd like to do. I want you to fill out just this, a couple of pages form right here. And what I'm going to do is have you fill this out. If you have any questions, I'm going to be right here. Just let me know. And then as soon as you're done with that, what I'm going to do is introduce you to the person who's going to be doing your assessment. And then they'll take you in and take care of everything. Do you have any questions right now? You need to use the restroom, want to drink water, whatever. Okay. So again, you are giving it the attention, and maybe, I don't know if I did a good job there or not. I'm just saying the attitude is very positive. It's very forward. It's like, you are the most important thing that's going on in my life right now. This is a huge deal that you showed up. I'm so glad you came. That's the attitude that you're bringing, not, I'm kind of busy here, and now I've got to break from what I'm doing to meet your needs. What do you need? Right. And I'm telling you, I've seen body language from staff that says exactly that. Okay, so any comments or questions about that little soapbox that I got on?
Yeah, I totally agree with all of it. I think our program, the one thing we're struggling with the most is the COVID protocols. We're losing so many. The COVID protocols are taking so long. I mean, our phone will ring off the hook with, "Hey, I need help." By the time we can get them through the protocols, we're losing probably 70% of our intakes.
Is that like because it's in the prison system? Is that because there's like a isolation or quarantine protocol that they need to follow before they come?
Well, I work with the county, so I don't work specifically with CDCR, but
Oh, okay.
we're a program that our contract is reentry, and Contra Costa County requires them to do COVID testing and quarantine for 2 weeks before they can get treatment.
Wow, that's so rough. That's so rough. Um, yeah. Wow. Yeah, I wonder, do you guys ever provide any resources like stuff that they can read or whatever, or do you guys do any connecting through that couple of week period, trying to keep the connection or anything?
We're not necessarily. Contra Costa County holds all that. They actually just hired, or opened 2 hotels so now when you call Access Line to get help, they will put you up in the hotel for the 2-week quarantine for your test to come back. They have on-site people there, and then they transport them to the program that
So
they're going.
but you couldn't call them there.
Yeah, we wouldn't know who they were until, yeah.
Wow.
And those are like the most critical 2 weeks there are from the time they want help to that quarantine where they already feel isolated. And now they've just been isolated so much more without a therapeutic alliance.
Right.
Yeah, it's horrible.
Yeah, we're losing the majority of our clients before they even get here.
Wow.
See where I'm working, when the clients come in, they're required to wear a mask, and they get an appointment to get tested the very next day, and they have to wear a mask the whole time except like when they're sleeping. But other than that, there's really no holdback on their treatment. They start immediately. They're in groups. They have to wear a mask. They cannot remove that mask for any reason, and they start right away. And I agree, that's the most critical time, because
Yeah.
that's going to decide on whether or not. I mean, they're an addict. They want recovery, and probably the hardest part was for them to make that initiation and want to come in to begin with. And so to prolong that, it's crucial, because that'll make them or break them. They'll decide, oh, I made a mistake, I want to go back out and use again. No, we need to get on it immediately, right now, while they're ready to do it, while they're committing.
Yeah, wow, that's really great that you're able to do that. Gosh, I want to send them the link to my videos in our free COVID period. I don't know if you guys are aware of this. I know some of you have been on the previous webinars, but I do have a free COVID viewing period of all of my DVDs. And if you're interested, I can send you the link. You can view yourself and or your clients any of my DVDs during this period, because I think because of COVID, and also because of what Michael just said, we are losing clients, and because of the distance counseling, there's a lot of video counseling going on. I think the education is actually suffering. So, all right, so let me go back to our slides. Okay. So, all right. So in regards to the client, the alliance, therapeutic alliance, engagement and treatment. So we want to build an alliance with a client, evaluate what strengths and resources they have, so they can that they can use to get what they want. So we're building the alliance. We're finding out what they want, what are their strengths and resources and support, so we can help them get what they want. Continued treatments dependent upon demonstrated engagement and outcomes. So the client must notice improved function and achieved goals, which are important to the client. So like if we just got a bunch of goals that you know, for the client, you know, that are our goals and they're meeting those goals, that's not going to be seen by the client as progress, right? We need to have goals that are framed toward what they want. So we want to keep in mind what is it exactly that they're trying to accomplish, and try to figure out a way to write those in into the treatment plan. And when risk or problems arise, focus on collaborative participant directed interventions rather than these like automatically triggered treatment interventions or level of care transfers. So as problems arise, as we're treating the clients, we want to treat them on an individual basis rather than going, okay, well, when this happens to a client, this is what we do. You know, everybody's case should be treated individually and evaluated individually, rather than, okay, well, if they relapse, this happens. If a second relapse happens, this happens. No, everything should be, every intervention should be individualized, and it'll keep it client-centered that way. So we mentioned motivational interviewing earlier. I may actually do a motivational interviewing webinar at some point. So we want to meet the client where they're at, so we don't judge, push, or expect what is not part of them. We want to start at their stage of change. We don't boss them around. We're coaching. I liken myself to, kind of a cheerleader. I'm rooting them on, right? And I'm flooding them with encouragement, and I'm not only focused on what they're not doing, and what they still need to do. I have a lot of focus on what they are doing, and we do want to restrain ourselves to realistic expectations, and encourage the client to create relevant goals, and establish goals and treatment plans according to the client's desires, not yours. So this is something that just develops. It's kind of an art, if you will. I mean, to try to put things on a treatment plan that are client-centered sometimes is difficult, and it may be that largely how we're doing that is as we are talking to them about what to put on their treatment plan, we are framing it as, these are the things that we're doing to keep you out of jail. These are the things that we're doing to help you get your kids back. These are some of the, this is what we want to do. And also at the assessment, I had mentioned that, oh, you don't want to be sober, you just want to stay out of jail. We can help you do that. What I usually like to add, and you know what? This doesn't have to be just like a waste of time for you where you're just getting out of jail. Hopefully you can pay attention and take some of the information in, because you're just going to learn some really good life skills here while you're here. So regardless of whether or not you decide to stay sober, you're going to really learn a lot about yourself while you're here. Here's kind of a little bit, what I mentioned earlier, that the best way to improve retention and outcome is to attend to the client's experience of progress and the therapeutic relationship early in treatment. Positive feedback on their progress significantly improves retention and outcome. And treatment in which the client cannot see progress by the third session doesn't result in treatment. So here's some specific things that you can implement into your program right away that can help with this. So the first is an early engagement, what I call an early engagement session. So this is EES for short. So what I've done with some programs is that every person who comes in for their second session actually has an individual session with their primary counselor. And in this early engagement session, we sit down with them and we go, how's it going for you so far? This is great. This is your second day. You showed up for your second session. Great job. How'd your first group go? How's it going so far? Do you have any questions? Do you think this is like something you're going to be able to, to stick with and go through? And, if there's any issues, we get them right there. What happens all too often is that individual session early on is not happening. and we are losing them before that first individual session even happens. They've gone to 2 groups, nobody's connected with them, they feel like just a number, and they're like, this is going to help me. Okay, so we want to make that connection, and we want to find out, are they engaged? How are they doing? And what can we do to to make this better for you if it's not going well? Okay, so every person second session gets what we call an early engagement session. Could be even just 15 minutes. And then the EESGF, which is early engagement session group feedback. So in this, doing this, regardless of what session you decide to do it, I usually recommend that it's in the 3rd or 4th session in group, right? And this is, hopefully you're able to take my suggestion and model your program to where people are in with the same group, with the same people as often as possible. So what you do is the 3rd or 4th session, you ask the group to provide that client some feedback, positive feedback, create constructive criticism is not allowed. It's only positive feedback, and everybody goes around the room one at a time, giving them positive feedback, and the counselor participates in that as well. And so, so even if it's just, great job telling us why you're here the other day. Boy, you're already participating. Great job, you showed up. Like this is your 3rd session in a row. Good, good job. I just really appreciate how it looks like you're paying attention to this. It's really great that you're still coming here, even though you don't even want to be sober and you just want to get out of jail, but you're still doing a good job. So whatever it is. And I recommend the 3rd or 4th session, and I would say that's probably a good time to do it, because if they're not seeing progress by the 3rd session, it doesn't result in improvement according to some studies. Okay, so we want to give them that feedback early on. Now, in regards to the initial treatment plan, so I have to like admit something to you. I, like many other people, have not really taken the initial treatment plan very seriously. It almost sometimes becomes like a placeholder, right? We do this initial treatment plan for everybody. Many times they're very canned. It'll say the same thing for every client. And it's just a placeholder until we do the real treatment plan. I have to admit, I've been guilty of this myself in the past. This idea that progress needs to be seen by the 3rd session to really make a difference lends to the idea that the initial treatment plan should be substantial. What I mean by that is have substance. It should have measurable stuff in it. Okay, so even if it's like the client is going to attend the first 3 sessions without missing, the client is going to show up on time for every group, the client is going to fill out this initial problems and goals thing. We created like this little problems and goals thing. There's like 5 things that basically is finding out exactly what the client wants, out of treatment. It could be very simple stuff. And what it does is it allows you, after that first 3 or 4 days, to have an individual session with them and review that and go, well, I know you missed that first session, but you attended 2 out of 3. That's good. So we're hoping that you're going to attend every session from here on out. Or, a great job, being on time. Or, when they show up for that 3rd session, it's like, hey, did you get your problems and goals thing, done? Oh, you didn't? Okay, well, check it out. Here's a new copy. Why don't you just sit right over here and fill this out? So at least on one of those things, you're able to say, okay, good job. You got that done. You partially did that, or whatever. So whatever progress they're making, you're giving them positive strokes regarding the progress, just so they can see that. And even if it's not perfect, you guys, they're making progress. It's, they say in the program, progress rather than perfection. And we want to be focused on what they did do, not on what they didn't do. Okay. Any comments on that? Okay. So let's see, oh boy, we gotta, I don't know why these things go so fast. Okay, so that is some initial things you can do. So the early engagement session is a chance for you to see how things are going so far. And then you got the group feedback thing, and then a substantial initial treatment plan that will enable you to note some progress for them. So what information do clients get from us about their progress? Do they hear observations consistently about how they're improving, or are we just constantly focused on what more they need to do? I have to admit, in the start of my career, I was basically like, okay, what is in the way of this person and their sobriety, right? And so it was all about what they weren't doing and what they still need to keep doing. And I didn't do enough focus on what they are doing. And that needs to be the primary focus, you guys, of what they're doing. If I'm just coming in and telling them what they're not doing, I'm becoming somebody from their past. I'm becoming somebody who just like has this agenda. And I'm, a lot of our folks didn't get any acknowledgement of anything that they did good by their parents. You know what? It could be those positive strokes that they're getting from you that keeps the client coming back because it feels so darn good. Okay. It's really important that we keep that coming. So it's the client's rating of the therapeutic alliance that is most important. I might think it's going really good, but it's their gauge of it. And then, as I mentioned earlier, the most important determinant in outcome is those who are engaged in the process, who are engaged and participating in the process. That's the most important determinant. It's like, wait, you might say, wait, I thought you said therapeutic alliance was the most important determinant. Well, here you go. The best predictor of engagement, which is the most important determinant of treatment, is therapeutic alliance they share with the counselor. So like, if you're going to size yourself up, you guys, against your peers, and like how you measure up to other people that are doing this work, if you do that kind of thing, well, that's where you start. You can compare yourself to other people that are doing this work by how well you develop therapeutic alliance. If you're going to be asking yourself, how good of a counselor am I? This is where you start. How good am I at developing that relationship with the client? Okay. And so here's what it looks like. So therapeutic alliance we're building, that leads to the participation, which then leads to the success, to the retention. Okay. And there's studies that show that the longer they stay, the better they do as well. Okay. So therapeutic alliance is where we start. So the highly individualized service delivery, rapid, formal, continuing feedback from clients regarding their plan and progress, so what we want to do, what I suggest is, don't wait until the end of your program to do a satisfaction survey. Satisfaction surveys are very valuable at the end, but we should actually be doing them early on. My suggestion is that you do a satisfaction survey with your clients. It could be brief, 5 or 10 short questions, basically gauging how things are going so far. Okay. And then you tell them that that's going straight to your quality assurance program. And then the quality assurance. So we had the people that received those, if there were anything that was marked like a 3 or below, or if there are any negative comments, then it was brought to the attention of the program manager, and then the program manager would intervene as they see fit. And the manager is part of the quality assurance program. So the manager might go to the counselor and say, you know what, I think such and such needs some attention. Pay attention to this area. Or there's been some comments from your group about that this is happening, so that we can, that we might be able to save this treatment just by knowing. So we've got the early engagement session in session 2, where we're asking them how things are going so far. And then we have, like, in session 5 or somewhere around there, we're actually doing a formal survey. And so we need to be responsive to their individual interests and goals, and we must incorporate feedback in their progress. So PRS there, that's a progress review session. In an IOP program that's say, 20 or 30 sessions or something, I would say, maybe doing this, somewhere in the first half of treatment, maybe like I think this program, one IOP that I was with for a long time, we did it about a week after after the formal treatment plan, the master treatment plan was developed. And in that session, we would review how that's going so far. Now, another way to do this is actually in the individual sessions. You should be having at least one a week. I would highly recommend. And in those sessions, you can actually be doing a PRS there and reviewing the treatment plan. I think reviewing the treatment plan is a great template for your individual session. And so I'm actually doing a webinar next week on treatment planning. I'm not going to get too deep into the actual treatment plan stuff here. So, goals and objectives made by the client. And then, so what I want to recommend on the treatment plan is, how we have the long-term goal, and then we have short-term goals or objectives to achieve the long-term goal. What we want to do is make sure that we're breaking those objectives, those short-term goals into good, little bite-sized chunks, ones that are going to be easy for them to achieve. If I've got, let's say, 2 objectives to achieve this long-term goal, let's say I made that 4 or 5 smaller ones. Guess what? They get to have 5 successes rather than only 2 there. Okay. It's more work, but I'll tell you, when they can see all of these successes, and since they can see that these are like really easy to do, they might be more apt to move forward on them. But if it's like, oh, these first objectives are like so hard, they're like, dragging their feet on getting started on them. So we want to make them really easy. We want to take their, I don't know if you guys use the SNAP, strengths, needs assessment, strengths, needs, assets, I think, and plan, I forget, but it's basically it's a tool that's used. I'm having a mind block right now. It's basically a tool where you're finding out what their strengths and weaknesses are, so you can build the treatment plan according what they're actually able to do. And yeah, so the bite-sized chunks. So then, okay, so in summary, so treatment works. Doesn't matter which therapy or evidence-based treatment is used. What makes the biggest difference is therapeutic alliance. So we're meeting the person where they're at, we're joining with them, we're connecting with them, we're aiding them in identifying relevant goals for their treatment plan, and we're providing early and ongoing positive feedback regarding progress on identified patient goals. And then remember that therapeutic alliance starts with the initial contact. If you feel like your front desk is not meeting clients with what they should be meeting them with, or whoever's answering the phones, I would bring it to your manager and say, hey, I'm concerned about this. Therapeutic alliance is really important. I'm trying to connect. If they're getting this when they call, I have to fight against that. And then the next important contact is the intake appointment. Stand there and check it out when somebody shows up, and see how they're greeted, or if you're around there and somebody shows up, just take note of it and see if there's anything you can do. So in regards to like individual sessions that are marked in early in treatment, so you got the the orientation where and the initial assignments. You can give them like an initial assignment, just maybe 4 or 5 questions, and that can be part of the initial assessment. The early engagement session, session 2, how are things going? Early engagement session, group feedback, session 3 or 4, where the group is giving feedback, not constructive criticism, all positive feedback. You got the master treatment plan session where you're getting their what they want to accomplish. So you're writing the master treatment plan toward what they want. You got a master treatment plan review session where you have them sign the treatment plan and review it. So, you're not just like, throwing it in front of them for 2 seconds, and, you're actually reviewing it, going over it, asking them if they have any questions about it. And then a progress review session, as I said, which is where you actually are reviewing their progress and giving them feedback. I recommended the pre-discharge satisfaction survey so we can see how things are going so far. And then we want to break up the short-term goals on the master treatment plan for their multiple successes. All these are going to be on the slides that you'll get if you don't have it already. And then positive feedback, positive feedback, positive feedback. You just can never give enough. That positive feedback can make it just feel so good. That in itself can really keep a client coming back. Take a breath, Bob. I know I had to like kind of fly through the end there. I hope this helps at least get you focused on, some directions that you might go in. I hope you've gotten maybe some ideas of how you can apply this stuff to your program. I just in the last minute or so, I'd like to maybe see if that has happened, and or do you have any things that maybe you want to add that you are perhaps doing at your program that are helping?
Bob, this is Melanie with Alaska Airlines. This is really great information. Just so all you know, Ava and I are both our EAP chairs in San Diego, and so we are that first intake when we're getting people into treatment. And I just, from what you're recommending that the treatment centers do, it's things that Ava and I can incorporate. I would love to get this PowerPoint emailed if possible.
I will do it today. Absolutely.
Awesome.
As we were going along here and you told me who you were, then I figured out, oh, that's why the airplane is next to Ava's name. I bet you they know each other.
Yes, Ava's my co-chair, and we have a new program at Alaska Airlines, and so we have a lot of flight attendants that are feeling free to come forward and supported by the company. So a lot of people into treatment, and for both of us, it's getting there, it's supporting them, it's what we can do, and I think we can take a lot of what you said and apply it to, speaking with them while they're in treatment, and putting that smile on your face and being that person that they can, rely on and call at any time. And so, yeah, it was all really good information for me.
Awesome. Glad you enjoyed it. And thanks for attending. I have a very fond memory of being able to speak at the first and second annual peer program conference that you guys had in, where was that? In
Baltimore.
Baltimore, yes. I got to go to an Orioles game too. So glad you guys are with us.
Of course, it was virtual this year, but we'd love to have you back.
Right, I would love to. So anyway, what I'm going to do now is I'm going to email you guys the post test and the survey, and all you have to do is press send, or no, I'm sorry, press reply, and then you can scroll down and edit, just put an X anywhere next to the correct answer, and then I will send you out your certificate. Any other comments before we go? Well, it's been an absolute pleasure having you guys here. I so much appreciate your participation. You've made it very easy for me. So hope that you're able to really take this information and have an impact on your individual programs in regards to your engagement and retention. If you need any extra help with that, just feel free to contact me. I'm more than happy to help you with that. Okay. Thank you. Stay safe. And until I see you next time, take care.